EGFR. I know that this was covered, I think, to some degree in a previous talk. It's a cell surface receptor for members of the epidermal growth factor family, and there are 4 of those components. EGFR is considered HER1, and there's a graphical depiction of EGFR signaling. You would have ligands, primarily epidermal growth factor, binding to the EGFR receptor, followed by phosphorylation here, and then a signaling cascade that ultimately leads to cell proliferation, angiogenesis, migration, adhesion, invasion, and so forth. So how would one apply testing for EGFR in patients with non-small cell lung cancer? First, we have to identify that EGFR is an oncogene, and there's been development, a lot of development and research in this space in the last 10 to 15 years, and there are now currently several approved drugs that target EGFR. In lung cancer, we have erlotinib, gefitinib, and afatinib, and more recently osimertinib. In other cancers, we also have cetuximab as an antibody. Mutations in EGFR could lead to constant activation of this receptor and downstream signaling, and this leads to uncontrolled cell division and growth, and makes the EGFR receptor and inhibition of that signaling an attractive target for this disease. So to bring you back to 2004, this was the several of the lines from this seminal paper in Science that looked at trying to identify who would be more susceptible to this EGFR tyrosine kinase receptor inhibitor, gefitinib. And at the time, patients weren't really, there was really no information on how to identify those patients other than they may be women, never smokers, and possibly of Asian descent. And so from this initial study, 15 of 58 patients, unselected from Japan, and 1 out of 61 from the US, were found to have a sensitizing mutation in the EGFR receptor, and that led to the explosion of molecular profiling in lung cancer and then subsequently in other solid tumors. And initially, when researchers and clinicians were trying to identify those who may best be suited for EGFR-directed therapy, immunohistochemistry was first used. And it turns out that in lung cancer, this is not a very successful strategy, especially when we're talking about EGFR TKIs. Also, FISH amplification of EGFR was looked at, and with data coming primarily out of University of Colorado, data was looking at mostly retrospective cohorts, but ultimately it was the EGFR mutation testing that's prevailed for not only predicting response, but also correlating with progression-free and overall survival. So applying EGFR mutation testing, we've heard in another talk, it can be analyzed through a variety of modalities. Primarily, Sanger sequencing was one of the initials modalities, and PCR. Melting temperature has also been used, tandem mass spec, and now high throughput sequencing, especially when we apply multi-gene next-generation sequencing assays. And here's a table depicting some of the pivotal trials for gefitinib. And if you can see the top here, this is IPASS. Tony Mock published this article in New England Journal of Medicine with his collaborators. It was a phase 3 study looking at gefitinib versus carboplatin paclitaxel, and showing a high overall response rate, with gefitinib compared to chemotherapy, and improved progression-free survival, but ultimately no difference in overall survival. And at the time when that came out, patients who had an EGFR mutation were directed to EGFR TKI therapy, not because of overall survival, but because the possibility of having a more tolerable therapy with less side effects overall compared to traditional cytotoxic chemotherapy. And subsequent to that, there have been additional trials, primarily coming out of Asia, showing that overall gefitinib compared to chemotherapy has a higher response rate, higher PFS, but no difference in survival. And the same is true with erlotinib in both European and Asian cohort, showing EGFR TKI having an improved response rate and median PFS, but overall survival not significant. And then moving forward in in a more recent study with afatinib, which is an irreversible tyrosine kinase inhibitor of EGFR. This was one of the first studies looking head-to-head in an EGFR mutant population compared to what would be considered a more traditional cytotoxic therapy of cisplatin pemetrexed. The median PFS for afatinib was 11 months compared to just under 7 months for chemotherapy, and this the population that seemed to derive the most benefit were the usual suspects for EGFR mutations, deletion 19 and L858R. And then looking at toxicity according to EGFR TKI, in general, erlotinib and gefitinib have a lower profile of toxicity for both common adverse events, rash and diarrhea, compared to afatinib, and this is believed to be due in part because afatinib has got that irreversible inhibition of EGFR TKI, of the EGFR receptor, and this may lead to both its increased efficacy in terms of response rate, but also catch-22 with worsening of toxicity, primarily rash and diarrhea compared to the other TKIs. And more recently, there is a third-generation EGFR TKI for the patient population who have progression on prior EGFR TKIs, and this particular molecule is designed to target mostly the 50 percentile group of patients that develop resistance, and they have the T790M mutation, which is a secondary mutation in the EGFR receptor, and we would see that in about half of patients who have EGFR TKI in first generation or second generation and then have progression. And from this pivotal study in the New England Journal of Medicine, Paciani, first author, you can see that at the top of this curve, those who had the EGFR T790M mutation had better benefit than those who were T790M negative, with a median PFS of 9.6 months for this group, which is very similar to what you would see in frontline EGFR TKI therapy for patients without the T790M, getting erlotinib or gefitinib. And the median PFS for the negative group with this molecule is just under 3 months. So over the course of treatment, especially with targeted therapy in patients who have an EGFR mutation, you can see the evolution of clonal resistance and other resistance mechanisms. So by following this diagram, a patient has an EGFR mutation treated with one of the first-line TKIs or erlotinib. You can have a separation of the clonality, where patients, about 50% of them will have the T790M mutation, and then if they're treated with osimertinib, can then develop, again, additional mutations. And this is an area of future study where now there is another mutation called the C797S, and then there's a group of patients who have other mechanisms of resistance to osimertinib. And those who have the T790M mutation can then develop less either absence or disappearance of the T790M mutation, and then develop additional mechanisms of resistance to osimertinib. And we heard from the first speaker about looking at circulating tumor DNA and plasma testing, and this has now been published in JCO in patients who have had osimertinib, that we can use and substitute in certain group of patients plasma testing. So if a patient is on an EGFR TKI, develops resistance, they can get two paths. They can either get a biopsy of one of the progressive lesions and send that off for sequencing. If they're mutation positive for T790M, they could get the third generation osimertinib. If they're negative, the recommendation would be chemotherapy. or if they have the primary resistance to, or developing resistance to first-generation or second-generation EGFR TKI, they could get now an FDA-approved plasma test and look and see if there's a T790M mutation. If there is, you can proceed with a third-generation TKI like osimertinib. If it's negative, then one can consider doing a new tumor biopsy for the slight chance that there still might be some discordance between what's detected in the plasma versus tissue. And if the T790M were positive in the tissue at this point, again, osimertinib, or if negative, chemotherapy. And there's some new data looking at how to address these developing mutations with this third-generation EGFR TKI. So from this paper, also by the group at Harvard and Dana-Farber, Paciani is first author here, and published looking at this mutation C797S, and with a new molecule that is not yet in the clinic, I believe, called EA1045, along with cetuximab in cell culture and in vivo experiments, you can get higher degree of tumor death and tumor shrinkage with the combination of this drug in patients who, or in samples that have this triple mutation. So that would be a near future clinical trial that we could expect to see both in the US and globally in patients as we get more patients who are being treated with osimertinib and then developing resistance to that. So I'm going to conclude now with my talk, and I hope that you could see from the slides I've presented that EGFR mutation testing should be used, and that for patients with non-squamous non-small cell lung cancer or those with never smoker squamous cell, it would be prudent to test for EGFR mutation. One could use tissue testing, and now there's the availability of plasma testing. And that would be primarily reserved right now for patients where it's inaccessible or unsafe to get a metastatic lesion or you don't have archival tissue available. Beyond first-line therapy, osimertinib can have a role, specifically in patients with the T790M mutation. And since few patients, just another thing to consider, since few patients are considered cured with targeted therapy, especially EGFR TKIs, and toxicities are not insignificant, there definitely needs to be additional research in what opportunities can be brought to these patients beyond EGFR TKI therapy. There are other works going on with immunotherapy. They have yet to pan out, I think, to be favorable. And then there's still chemotherapy with cytotoxic drugs as a possibility when EGFR TKIs have run out of steam. And with that, I'll end my talk, and I think we're going to have a roundtable next. Thank you very much.